Welcome to the Ortho on the Go podcast. My name is Chuck Dowell, host of the podcast. This is an educational orthopedic podcast focused on discussing both clinical and functional orthopedics. We will discuss a variety of topics within the field of orthopedics, including reviewing interesting cases, hearing from different professionals throughout the orthopedic profession, and discussing common musculoskeletal injuries and complaints. This podcast is meant for anyone that wants a better understanding of orthopedics, including all levels of practitioners, coaches, parents, and athletes themselves. Hello, everybody, and welcome back to the podcast. Today, I have the pleasure of discussing ankle sprains with Dagan Cloutier. Dagan is a physician assistant that practices in the northeast part of the United States. He is the editor-in-chief of the JBJS and JOPA Journal. Dagan, can you tell us a little bit about that?
Yeah, so since 2016, I've worked with JBJS and been the editor of JOPA, and so that has definitely helped keep me motivated to read and stay on top of all these topics.
And then you also have your website, CME for PAC, right?
Yeah, so I've been writing self-assessment questions for CME for PAC for about 10 years now, and that's another thing I love is just seeing case studies in the clinic and writing a discussion section. And honestly, really, when you write a discussion section or any type of case study and you take a deep dive into the literature, it really helps you with patient care decisions, right?
Yeah, I would agree with you. I think that's definitely a great opportunity for you to educate yourself on a variety of different orthopedic and or general conditions. So when we're talking about ankle sprains, how would you kind of categorize, let's say, acute ankle sprains?
The big ones for me, in terms of the categories for acute ankle sprains, and that's a big enough topic to go over in one night, is acute ankle sprains as opposed to chronic. But acute ankle sprains, they can be broken down into, for me, your simple lateral ankle sprain, and that has different severities. But then you have your avulsion fractures, your high ankle sprains, and then your long-term pain, like when you start getting bone bruising and stuff like that. So those are the four major categories, I guess, I think about when I see ankle sprains come in.
Yeah, I don't disagree with you at all. I agree on that. And I think, like from my perspective, I think the mechanism of injury always plays a lot into it. If they have an actual acute injury that's related to it, if they can weight bear on it, that type of thing. And then, where their palpable tenderness is, make sure not to miss, syndesmotic injuries or Mason-Neve injuries. I just had one the other day that, the urgent care treated her, put her in a boot, and she's like, well, everything's great, but it hurts right here at the top of my boot. And sure enough, it's kind of her lateral fibular area. And I palpate and she jumps off the table and I get an x-ray and it shows that she has a fracture of her proximal fibula. And, they were just treating the ankle sprain. So
right.
I think it's important, joint above, joint below for the evaluation.
Yeah, you essentially, when you diagnose acute ankle sprain, you have to have an x-ray to rule out a fracture. So we're assuming that the x-ray has been done and it's been ruled out. And in terms of a lateral ankle sprain, I would key into that lateral ankle sprain diagnosis by palpation, right? So my main palpation is lateral anterior talofibular ligament. So that, the most common ligaments it's sprained. Palpate laterally, and that's usually where the significant swelling and tenderness is. And then I slide over and palpate the anterior syndesmosis as well as the medial deltoid. And so if I just have most of the swelling laterally and no tenderness over the deltoid and anterior syndesmosis, I can assume that it's a lateral ankle sprain. And again, those can have different levels of severity. When I talk to patients, I try to be more visual with patients. And so I'll say, when you sprain your ankle, your ankle ligament's like a rope. And when the rope tears, and I'll interlock my fingers as if I'm forming a rope, I'll say, when the rope tears, it splits apart and all the fibers tear. And then I'll pull away my interlocked fingers and I'll visually show patients that it's like two mop heads when it's torn. And the healing process involves all those fibers coming back together and healing. And when you exercise too early and you don't allow, or you don't boot the ankle or protect the ankle from rolling again, then you don't allow those interlocking fibers to heal in. And if you sprain it while it's trying to heal, and I pull my fingers apart again to show that you're basically interrupting the healing, and as you interrupt the healing and you don't treat it appropriately, then you end up with a loose ankle. Then the fibers heal loose, and you're more prone to ankle sprains in the future. So I feel like that visual of like the interlocking fingers and telling them the ligament's like a rope that tears that needs to heal in. It's sort of a simple visual for patients to understand the healing process and what was actually injured.
I think that's a great analogy. I think that works well as far as the patient's trying to visualize exactly what the injury looks like from a ligamentous injury perspective. So if a patient comes in and is having and or has an acute ankle injury, what is your, I guess, go-to initial treatment regarding this? Let's say from an immobilization perspective, what do you use to help protect that joint? What's your recommendation for that?
I oftentimes start initially with the walking boot and really feel patients out. And I can tell immediately almost what their reaction is. I'm not going to wear this boot. Throws off my hip, throws off my gait. It's uncomfortable. And of course, I try to sell it. This is the best option where you can just set it and forget it. You can wear it, and if you step on an uneven surface with this boot, your ankle's not going to roll. And if they still are not interested, then I talk about walking on even surfaces for 3 or 4 weeks and being very careful to go walk in the yard where there's an uneven surface or they're more prone to roll their ankle in certain terrain.
I think I've learned that over the years that if you educate the patient upon, on your thought process and they are a part of the decision-making process, a lot of the times they'll feel more comfortable with the decision, feel like they have some control over that, and that leads to better outcomes for the patient. Yeah, so we've talked about how important it is to involve the patient in the decision-making process and how important it is to educate the patient regarding the specific injury. Let's discuss this scenario. Let's say a friend calls you up and says, hey, my buddy or my kid or myself, sprained my ankle at a basketball game today, or maybe I missed the last step walking down the stairs and I twisted my ankle. Do I need to go in and get x-rays? Do I need to go in and get this checked out? What do you tell them as far as when to seek treatment for ankle sprains and when it's amenable to just treat it at home?
I think any pain with weight bearing has to be seen, has to get an x-ray, has to be seen. If they feel like the ankle is significantly swollen, I believe that they should be seen just for an exam in terms of ruling out a syndesmotic injury. So it comes down to severity. If the ankle just feels unstable, they should be seen. If there's any significant swelling, they should be seen. If I guess they don't have any lateral swelling and you're just your typical slight roll, but they were able to continue playing in their basketball game, potentially they don't need to be seen. Those happen all the time. I have the fortunate where I played a lot of sports and I've been through a lot of injuries so I've sort of have a good feel of sports related injuries in general. I mean, if people roll their ankle all the time in soccer and basketball, but they don't necessarily have a severe injury. So those are the things that I look for.
Yeah, I think I would agree with you on that one. Like I said, for me, at least a lot of orthopedics is based upon the mechanism of injury. If somebody, misses a step coming down the stairs, I always ask them how many steps, because for me, if it's 3 steps versus 1 step, that could be a more significant injury. Like you said, if it's an athlete that twisted their ankle, let's say they came down from a rebound or, they stepped on somebody's foot, if they're able to finish that game, then I think, yeah, soft tissue injury, but maybe the severity of the injury is not as much. Yes, they're going to have increased swelling that night and for the next few days, but it was stable enough for them to play on it at least for a short period of time. So maybe it could be more conservative with that treatment than somebody that injures it and can't weight bear right away. I think more significant structural damage maybe needs to be seen, and more significant immobilization and or weight bearing restrictions, if that makes sense.
Yeah, no, right on. Yep.
Do you ever use the Ottawa ankle rules? Have you heard of those?
I have, but I just think that instead of memorizing, 4 or 5 rules, to me it's common sense. I mean, if they have pain to palpation, bony palpation over the lateral ankle, if they have pain with weight bearing, if they have significant swelling, uh, just get an X-ray.
Yeah.
It keeps it simple in the decision making instead of having to try to hit every bullet point of the auto rules.
Yeah, and I agree with you too. I get a lot of students that come in with the Ottawa rules that they're taught in their schooling, and we don't have socialized medicine, at least in the United States. And so, our ability to get X-rays on patients, it usually is not significant. We usually, most people can't walk in an orthopedic clinic without getting an X-ray. Now, some patients that don't have insurance and are self-pay, you could potentially use these rules to evaluate where you should X-ray, because that's part of the components of the rules is should I get ankle views or foot views? But, most of our foot and ankle docs get 5 views, 3 views of the ankle and 2 views of the foot on everybody, independent of what you come in for, just to kind of make sure we don't miss anything. So, like you said, I think it's common sense um, from an aspect of when radiology should be done.
Yeah, and I work in an urgent care setting, as you do, and um, I try to be a minimalist as well in terms of if you examine them and all the tenderness is around their ankle, and you have no tenderness over their fifth med or over the dorsum of their foot, I tend to just get ankle X-rays. I am sort of cognizant of costs and just over ordering as well. So I try to keep it simple in that decision making as well.
You said something which I agree with completely, is individualizing the treatment based upon the patient's kind of needs and the severity of the injury. I think oftentimes patients will come in and they'll have a fairly large soft tissue presentation, quite a bit of edema diffusely throughout the ankle, lateral and or medial, quite a bit of ecchymosis diffusely throughout the ankle area, and their X-rays will kind of end up being negative. What Take us through like your thought process on these patients where, maybe it is a significant soft tissue response, but radiologically the X-rays all look okay.
Yeah, no, if it's a significant ligament injury, I tell patients that it's going to be a minimum 4 to 6 weeks on that lateral ankle sprain. And now that doesn't include high ankle sprains. So let's just say that they don't have any anterior syndesmosis pain or medial deltoid pain, just lateral pain. I will lock them in a boot, and I'll tell them you only have to wear it when you're walking. And it's essentially to prevent your ankle from rolling as that ligament's trying to heal. Now they can get out of the boot and work on um, some ankle pumps, simple exercises like that. I'll shut them down for 3 or 4 weeks just to get all the swelling down. Um, and sometimes 2 or 3 is appropriate, depending if it's less swelling. Get all the swelling down, and then I would typically get them into physical therapy at that point. But I'd also transition them to an ASO. So you don't want to just get out of the boot and go back into a sneaker. You'd want to get them in an ASO, and I typically, the cheapest way to do it, if we don't have the braces, the ASO type stabilizing brace in our office, I'll go on Amazon and I'll show them a picture of it. That's the brand we use, ASO. It's a figure of 8 stabilizing brace, and the cheapest way to do it, I think it's $40 on Amazon. Get it ordered, and you transition to that from the boot. And now that you're wearing a minimum of a couple months after the boot, you'd wear that stabilizing brace anytime you're walking. So if you catch an uneven surface or your ankle rolls, it gives you a little support. That combined with physical therapy, and in physical therapy is another set of eyes that can help transition patients back to either sports or work, where they're seeing the patient a couple times a week and working on stabilizing exercises, single leg hops, things like that, and they can progress patients back into their activities. Whereas I don't typically get to see that patient twice a week. So I'll have that initial evaluation and I'll spell out this treatment plan. And I may not even see him after the initial evaluation. I may just say, this is the game plan, physical therapy, and they'll work to clear you. And if you have any trouble beyond 8 weeks, 6 to 8 weeks, let me know.
Yeah, I feel like there's a lot to unpack, regarding, these ankle sprains because there's, we've all been burnt in the past by, a lateral ankle sprain kind of healing and patient having pain 8 weeks down the road and it ends up showing, you end up getting further imaging like an MRI and it shows possible like peroneal tendon tears that can happen with these lateral ankle sprains and kind of are hard to diagnose, at least acutely, because the tenderness and the soft tissue response is similar for both of the injuries. So I think directing the patients on potentially when to come back and when maybe further imaging is necessary based upon the progression of their symptoms is important. Like you said, hey, at 6 to 8 weeks, if you're not noticeably improving, transitioning out of the boot, progressing with physical therapy, getting into 70, 80+% improvement, I would consider coming back and following up. We may need some further images to make sure we're not missing anything. Like I said, I try to educate the patients on, when that potentially follow-up visit and or further imaging may be necessary.
Yeah, and I believe you can kind of tell a risk stratify that right off the bat. If their ankle is just completely blown up, they're at a huge risk of having bone edema. And that's the kind of patient that it may take them 4 months to get better. Whereas if the patient has moderate, mild swelling, particularly laterally, then they are probably going to do better. I tell patients a personal story of me when I was playing basketball a few years ago. Typical jump shot, came down, landed on someone's foot, and my ankle buckled, and um, I had immediate pain, swelling, couldn't bear weight, and it typical rehab, boot for a few weeks, then ASO ankle brace, and then I started running about the 6 to 8 week mark, and my ankle blew up again, and I I couldn't understand like that. It seemed like I had fully rehabbed from the ankle. The sprain, the pain and swelling was gone with range of motion, but I was still getting pain with running. And so I jumped in we have an MRI at our practice, and my talus lit up like a Christmas tree. There was bone marrow edema at 8 weeks throughout my talus. And it really kind of, a light bulb went off. Like, these ankle sprains, that this is why they can last so long, is because of this bone marrow edema in it. And it took me 4 months to run pain free. And so from the significant ankle sprains, I tell that story to my patients. I say, listen, that bone marrow edema takes 4 months, and that's the severe ankle sprains. That's why they can take forever to get better.
Yeah, and I try to educate patients on that too. I had a similar scenario playing basketball, and my ankle blew up, and I could have sworn that I broke my ankle. But I went to see the doc, got X-rays, and the X-rays just showed kind of a normal X-rays, maybe a grade 3 ankle sprain. I had to talk him into giving me a walking boot, and again, I used to very similar to you. It took me probably 4 to 5 months to get better. And I always try to educate them that the unpredictability of soft tissue injuries is probably more difficult than bony injuries. I mean, we know predictably a lot of bony injuries. If there's, let's say, a distal fibular fracture, heals in a fairly predictable fashion, 6 to 8 weeks for bony healing. And we're able to keep them non-weight bearing for that time. For these soft tissue injuries are very unpredictable. They could, as you said, take 2 weeks to get better. They could take, 4 to 6 months to get better. And so they have to be very patient with the healing process.
Yeah, and I would say, 9 times out of 10, you get an X-ray at 8 weeks, and it just shows persistent swelling in the lateral anterior talofibular ligament, as opposed to an osteochondral defect or a peroneal tear or bone marrow edema. But that's, it's at 8 weeks to 3 months is when you start thinking the MRI, trying to rule those other injuries out.
Yeah, correct. Because I mean, even if they do have a peroneal tendon tear or another injury, that potentially is not something they're going to repair acutely. That's something that probably treat in that more prolonged fashion at that 3 month point, even if it needs, require surgical treatment at that point. So, again, I try to educate patients that, if you do have a significant, let's say, syndesmotic injury, a lot of the times the imaging like an MRI is not going to change what we're going to do. We're going to immobilize you and make you non-weight bearing and then see how your symptoms progress and discuss, further imaging based upon that progression of symptoms.
Yeah, and you bring up a good point about high ankle sprains. And now a lot of PAs, I think, get confused of what exactly a high ankle sprain is. And
Hmm.
so I think and even in the general sports medicine world, like what is a high ankle sprain? In my opinion, how I diagnose it is they have syndesmotic tenderness, right? So they have tenderness over the deltoid, they have tenderness over the anterior syndesmosis, and they have lateral tenderness. And most of those patients with high ankle sprains come in with pain with weight bearing. So the typical lateral ankle sprain, they can walk pretty well. Even in a high ankle sprain, if you throw a high ankle sprain in a boot initially, most of the time they still have to use crutches because they still
Hmm.
feel that pain with weight bearing. They still feel that instability. So that's when I key on to talk to patients about a high ankle sprain and just say it's a much more severe injury. I mean, instead of your typical 4 to 6 weeks for a lateral ankle sprain, you're talking at least 2 months for a high ankle sprain to get back and a period of non-weight bearing. So it's a much different injury.
Yeah, I agree with you. Like you said, and I think you bring up some key factors there that I think are good teaching points for a lot of, young practitioners is, somebody that comes in with this kind of, mechanism of injury consistent with a lateral ankle injury, but also has medial deltoid tenderness. You got to key in that this could be a more significant injury to cause this deltoid ligament pain. It's like we're taught if somebody comes in and has a distal fibular fracture, whatever Weber classification may be, with this medial tenderness, you may consider that a functional bimalleolar fracture, or you may consider that more of an unstable fracture and probably more prone to make that patient non-weight bearing because of that, because that deltoid tenderness signifies possible, syndesmotic or instability within the ankle. And I think that's important to recognize is that anybody that comes in with deltoid ligament or medial ankle tenderness, you're probably going to be more prone to make them non-weight bearing and immobilize more significantly.
Great point. Yeah. So that's what all my foot and ankle docs will say is you have, and we always ask it. All right, we have this distal fibular fracture. Do we keep them non-weight bearing or can we let them weight bearing? Can we let them weight bear? Right. It's always medial tenderness. Right. If they have
Yep.
tenderness over the medial deltoid, you gotta put them in a boot and non-weight bearing. It's an unstable injury.
Yeah.
If it's a non-displaced distal fibular fracture and they have no deltoid tenderness, then you can think of if they feel comfortable weight bearing, weight bear them.
Yeah, I agree with you completely. And that's the first question I ask when students present this to me. And that's the first question my doc asks me when I send them a picture of my, distal fibular fracture that's maybe a Weber B or kind of right at that joint line, concerning for surgery or not surgery. He'll say, do they have medial tenderness? And a lot of the times they'll get stress views, which we, don't necessarily do in the urgent care setting, but just to evaluate to see if there is a ligament, syndesmotic injury that potentially would be more surgical than non-surgical. I think the other thing, to talk about, like we discussed, is this proximal fibular tenderness as well. I always start my ankle exams at that proximal fibular area because I can't count how many times, I've seen or, I've had missed proximal fibular fractures, this Mason-Uve equivalent type injury to the ankle. And so for me, when I'm starting my foot and ankle exam, I always start first thing I palpate is that proximal fibular area, and then I work my way down.
Yeah, no, I agree. Of course, X-rays, you know, um, for the bony injury too. And in terms of syndesmotic injuries and weight bearing, stress views and stuff like that, I guess I'm more of a minimalist as well. Like if I see medial clear space widening on initial X-ray, then that's when I'll establish the diagnosis. If there's no clear space widening, I get on initial films. I guess I don't look for it. I guess I don't get weight bearing films or stress views, even if they have medial deltoid tenderness. I assume that it's stable enough where they wouldn't need surgery. Um, and I don't know if you have a different point of view here. I'd be curious, but I guess I don't chase it. If the initial clear space is equal, if there's no significant clear space widening, then I will just diagnose them with a high ankle sprain, keep them non weight bearing, and treat them like that for 6 weeks typically.
Yeah, and I think those kind of further imaging sometimes and a lot of the times are more when they follow up, because I, I think there's two different examinations. When somebody comes in and they have an immediate ankle injury, I think, it's important to palpate the bony prominences. It's important to palpate the soft tissue structures. But, is a Taylor tilt test, is an anterior drawer test, is a, dorsiflexion, external rotation kind of syndesmotic test going to change necessarily what you're going to do? Or are you going to get a false positive with that test because of the severity of the soft tissue injury the patient has? And sometimes I won't necessarily do all those tests on patients that come in with these acute injuries because I'm going to get a lot of false positives just because of the severity of their injury. I think those are things that they can reassess when they come back after a couple of weeks of allowing that soft tissue to rest. And then they can get those stress views or weight bearing views, or maybe do those, more ligamentous exams to make sure that there's not going to be a concern for chronic instability.
Yeah, I know. And I guess that initial, when there's their initial evaluation, when they're so swollen, so painful, to do stress views, to do weight bearing views is kind of torture. So you bring up a great point, is maybe seeing them back a couple weeks later, and potentially if there's concern doing those, but initially for sure, just relying on your initial syndesmotic view and AP view of the ankle to view to see if there's any clear space widening.
Yeah, I think when patients come in with these acute injuries, I have a lot of PA students and young PAs that get so excited about, going through all of the tests that they learn to kind of diagnose what's going on. And I think a lot of these tests get false positives on them because somebody's coming in with such an acute injury that it's hard to really use those tests to delineate if there is a concern for that type of structural injury. So I think for me, at least with these initial acute traumas or injuries, it's all about palpation and the mechanism of injury to try to diagnose potentially what's going on. And then, like you said, immobilizing and giving the soft tissue time to rest and maybe reassessing in a couple of weeks, and then maybe doing more of those ligamentous exams. When we put somebody into a walking boots, oftentimes they ask, how long do I have to wear this? And you had mentioned only wear it when you're up and ambulating. I'll sometimes have them wear it consistently for the first 3 to 5 days just to kind of allow the soft tissue to rest. Because I think sometimes, the heaviness of the sheets, dogs, cats, brothers, sisters, whatever it may be, can sometimes bump the ankle and cause it to be painful. So I'll occasionally tell them to wear it kind of, all the time, except removing it for some passive pain-free motion and some icing activities, just to allow that soft tissue to rest for 3 to 5 days to get them out of that acute phase. I've even seen some of our docs, and I don't know if you've seen this before, put them in cast initially just to let things calm down. Have you seen that before?
No, honestly, I have not my practice, and I never use casts really for any type of stable ankle fractures as well. I just think the patient's ability to shower without a cast and ice it without a cast is just so much better for them in terms of compliance too. It's like, the lower extremity cast is pretty brutal.
Yeah, I think it's kind of a bit of an old school mentality, but I remember this distinct story. We were the team docs for a local kind of Division III college, and the athletic trainer was a good friend of mine, and she sent one of the athletes in that had an ankle sprain, and we had a retired orthopedic surgeon who was just doing clinic-based stuff, and the athlete came in and saw him, and he put him in a cast, and goes back to see the athletic trainer in a cast, and she calls me up and goes, "What the heck's going on here? Like, I can't do any of my modalities with this cast on." And I thought it was funny, and I've seen it since then, but I think some of the old school mentality will come through occasionally just to allow that complete soft tissue rest, maybe not trust the athlete to give it, the rest that it needs, and they'll put them in a cast just to mobilize. But it's a controversial topic whether that will create increased stiffness within the area,
Yeah,
secondary to that immobilization.
that's what I've found is if you lock them in too long, say you lock them in for 3 or 4 weeks, now their heel is completely tight, and now they're fighting, heel tightness, gastroc atrophy. Some of them develop plantar fasciitis right off because their plantar fascia is so tight from sedentary being sedentary in the boot and not stretching their heel. So it can snowball. It can make an ankle sprain, develop complications at 4 to 6 weeks that you have another 4 to 6 weeks to fight through,
Yeah, I think it's walking a fine balance between kind of mobilizing them long enough and preventing the patient from being their own worst enemy, which some of us kind of always are, as far as allowing that soft tissue to rest and heal, but not too long to create that soft tissue stiffness. Just one more thing to touch base on. What is your, so most patients that come in, especially young athletes, their first question to me is, can I play through this, or when can I go back and play on this? If they have a sport or activity coming up, or, let's say somebody's out road running, training for a marathon, and they're like, I have a marathon in 3 weeks, what do you educate patients as far as that's concerned? It's always, when can I get back to sports? When can I play on this? When can I be active again?
That's a great question. Some people will punt that to physical therapy, just say, oh, physical therapy will do some plyometric exercises with you and clear you. But I try to take it a step further. When I educate patients, I say, listen, if you can start doing some single leg hops independently, some double leg hops, some running, cutting, first you have to have pain-free range of motion. If you have pain-free range of motion, start to jog. If you don't have any pain after a week of jogging, that essentially to me rules out bone bruise or some of the other more serious injuries, peroneal tendon tears, osteochondral lesions. So if you have pain-free running after a week, start doing some running, cutting, single leg hops, double leg hops. And if you can do that pain-free, then I would say you're ready for starting to practice and game action. And I think most therapists are on board with that. That would be my conversation.
Yeah, like you said, I think, the therapists obviously have the benefit of maybe seeing them more often, a couple times a week, and watching the progression of their soft tissue swelling reduce and their ability to mobilize, improve. But I agree with you. I think, pain-free range of motion and then kind of near full strength back is kind of my, components of when can I start back to sports activities. And I think it's obviously all individualized based upon the patients, their expectations. If it's a senior football lineman and he's like, hey, I really want to play in this game, and he doesn't have that bad of an injury, you can tape it up and let him go play and just deal with the soft tissue concerns afterwards. So there is definitely this individualization based upon the expectations for each patient.
And I tell patients they should, if you have a significant enough ankle sprain, you should wear the brace for a minimum of 6 months in sports, because you see it all the time. Patients come back 3-4 months and they re-roll it without any type of stabilizing brace. I feel like you need that extra support, that extra confidence for at minimum 4 to 6 months after an ankle sprain.
Yeah. Yeah, I agree with you. I agree with you. And, I always have fun conversations with my physical therapist regarding this, because they're always like, hey, let's get them out of the bracing so they're not relying on these external devices for stabilization. And, I have a similar thought process to you is, I think it's important to wear that to prevent re-injury. So there definitely is some back and forth for that. And again, I think it's dependent upon the patient and the progression of symptoms.
Yeah, no, the figure of eight brace typically doesn't restrict motion. It doesn't restrict full, full strength. So it's just an extra layer of protection, so that they don't roll it again and they regain their confidence over that 4 to 6 month period.
Well, perfect. Well, I appreciate your time. Anything else, you can think about when we were kind of discussing this topic?
Uh, no, I think we caught a lot of it. I guess one last thing I would mention is, because you see this a lot too, is these avulsion type fractures. You see it on the lateral distal fibula. You see it on the dorsal talus and dorsal navicular. And patients will come back and they'll say, they said I had an ankle fracture, and I talked to them about, basically that's more of a soft tissue injury, right? So the ligament complex attaches to the bone and it may pull a sleeve of bone off. But to me, that represents more of an ankle injury. So that's a stable injury, something you can weight bear through, something we treat with the same timetable as an ankle sprain. The distal fibulas, if it's just a slight little avulsion type fracture, to me, it carries that 4 to 6 week type of protocol as an ankle sprain would. So I think that's another thing worth mentioning to your listeners is, how to treat those avulsion injuries.
Yeah, and I would agree with you completely on that. I think how many times have we been sent, patients that come in from an outpatient, facility, and they say, "Hey, they told me I have an ankle fracture," and you kind of look at their X-rays, and it's one of these avulsion injuries, and you kind of have to educate the patient that it's more of a soft tissue ligamentous injury than it is truly an ankle fracture injury, and will still heal in more of a predictable fashion, as you said. So I definitely think that's an important point.
Yep.
So regarding, if anybody's listening and they want to kind of access, let's say the JAPA journal and or the, your website regarding your CME, how would they access that?
Yeah, so you could simply Google JOPA, Journal of Orthopedics for Physician Assistants. You can go on our site. Our contact information, our instructions for authors are on the website. We are always looking for PAs to write, whether it be case studies or literature reviews, or even to review, peer review some of the articles that are submitted. And it's really kind of an easy process. I just send you maybe an article or two every 6 months. And I think a lot of PAs find that rewarding and stimulating. So yeah, no, they can visit the website and definitely get involved. We're always looking for PAs to help out.
Awesome. And then I think, your website, CME for PACs, is a good resource to get some category 1 CMEs if necessary for, a nice affordable price. And, if somebody's studying for, the test, it does a good review as far as, like you said, those questions that you may see on the test, and kind of how to study and or practice those. So I think that's helpful as well.
Yeah, no, the CME for PAC site is a great resource. It's we have several hundred self-assessment questions broken down in different orthopedic subspecialties, all written by PAs, all case studies. Most of them have images, real cases that we're seeing in clinic. So it's just a great review, general orthopedic review for someone that, especially if you work in spine and you want to brush up on some foot and ankle cases, or any type of subspecialty. If you get pinholed in sort of you just work in arthroplasty, right? I think all PAs should have some sort of general orthopedic knowledge, because we do have the tendency to switch subspecialties throughout our career. You could be a joint PA, then a great trauma job opens up. So it's CME for PAC does a great job of keeping PAs familiar with all areas, all orthopedic subspecialties.
Excellent. Well, I appreciate your time today. Thanks for coming on and discussing ankle injuries. Hopefully, we can get you on in the future and maybe discuss another topic.
All right, thanks, Chuck, and thanks for doing this. I mean, to really educate PAs in our profession, I feel like it elevates our profession, gets PAs motivated to learn by listening to the podcast. So great work, and looking forward to working with you again.
All right, sounds good. I appreciate it. Have a good night.
Well, thank you again, everybody, for listening to the podcast. I hope you enjoyed the episode. I think this was a great discussion regarding ankle injuries and how to treat them, both acute and chronic. Please, again, follow us on social media, both Instagram and Facebook. Please, subscribe to the YouTube channel to watch if any x-rays or videos are associated with these podcasts. And please feel free to comment regarding any episodes or discussions you'd like to see covered. Thank you again.